Usually when we talk about medical diagnosis, there's this expectation of precision, right?
Oh, absolutely. Like you want a clear answer.
Exactly. I mean, you break your arm, the x-ray shows a jagged white line, and the doctor points to the film and tells you exactly what needs to be fixed. We really like our medicine visible and, neatly categorized.
Yeah, we like a clear roadmap. But that is definitely not what we're talking about today.
No, not at all. Because when you step into the world of postpartum physical recovery, specifically pelvic health, that diagnostic x-ray machine is completely useless. We are looking at a landscape that is incredibly murky, dealing with tissues and mechanisms that are, well, they're mostly invisible.
It's the definition of diagnostic muddy waters, really.
Right. So welcome back to the Deep Dive. Today we have a very clear mission for you, the listener. We are mapping out the answer to a highly specific but universally crucial question. And that is, when exactly should childbirth-related vaginal and pelvic floor laxity be reassessed?
And this is such a huge topic because, well, the symptoms are typically only felt by the person experiencing them. So to build an accurate timeline, we really have to pull from multiple disciplines.
Which is exactly what we've done for you today. We're synthesizing a massive stack of sources. We've got clinical guidelines from NICE, the World Health Organization, and the Royal College of Obstetricians and Gynecologists.
Right, the big hitters. Plus, we're factoring in real-world protocols from specialized perinatal pelvic health clinics and, peer-reviewed data from aesthetic gynecology and tissue regeneration journals.
Yeah, we've got a lot of ground to cover, but the major takeaway hiding in all this data, the hook that completely upends how we think about recovery, is this traditional 6-week postpartum clearance.
Oh, the famous 6-week check.
Right. It is a medical myth. I mean, true tissue healing takes much closer to 6 to 18 months.
Yeah, that 6-week mark is, well, it's just scratching the surface. And I think we need to define laxity right up front, too, because popular culture brushes this off as a purely aesthetic concern, like a feeling of looseness.
Right, like it's just about bouncing back to a certain look.
Exactly. But it is a fundamental functional issue. Laxity is intimately linked to urinary incontinence, pelvic organ prolapse, and long-term sexual dysfunction.
So it's not cosmetic, it's structural.
Highly structural. Getting the reassessment timeline right is vital for long-term physiological health, not just, returning to some pre-pregnancy aesthetic.
So to understand when to reassess, I guess we have to completely dismantle that cultural expectation that a human body bounces back by that standard 6-week checkup.
We really do. The data paints a very different picture of what is actually happening under the skin. The physiological reality makes full recovery at 6 weeks biologically impossible.
Biologically impossible? That's a strong statement.
It is, but let's look at tissue healing on a cellular level. Research shows the abdominal wall has only regained about 51 to 59% of its tone at the 6-week mark.
Wait, really? Just over half?
Barely halfway there, yeah. And the connective tissues and fascia, the physical scaffolding supporting the pelvic organs, those take 6 to 12 months, or even longer, to regain just 80% of their pre-pregnancy tensile strength.
Wow. Just 80% after a whole year.
Exactly. The connective matrix simply cannot rebuild its collagen structure in a month and a half. It takes time.
So it's kind of like, and this is what I always think about, taking a cast off a broken arm because the bone is just starting to knit and immediately telling the patient to go lift weights.
Yes, perfect analogy.
I mean, that would be considered malpractice, right?
Right.
But we routinely clear women for all activities at 6 weeks when their core support system is operating at half capacity. Shouldn't clearance be progressive?
It absolutely has to be progressive, especially when you factor in the hormonal environment. Like during pregnancy, the body produces a hormone called relaxin.
Right, the one that makes everything loose.
Yeah, its exact job is to remodel collagen, to loosen the ligaments in the pelvis, which allows the baby to pass through the birth canal. But here's the thing. Relaxin doesn't magically vanish the moment the baby is born.
It sticks around.
It does. Its half-life in the postpartum body means it lingers, actively keeping ligaments loose for 5 to 6 months postpartum.
Okay, so let me get this straight.
Yeah.
You have muscles operating at half capacity, a fascial support system that requires nearly a year to rebuild its scaffolding, and on top of that, a hormone actively fighting that tightening process for half a year.
That is the biological cocktail, yes. And it explains why symptoms of laxity, like a sudden feeling of heaviness in the vagina or, stress urinary leaking, frequently don't even emerge until after the 12-week mark.
That makes so much sense. Because at 12 weeks, maybe the sleep deprivation is lifting slightly. You feel a surge of energy, so you pick up a heavier toddler or you try going for a light jog.
Exactly. And the demand suddenly outpaces the functional capacity of those weakened tissues, and the system fails.
The structural load just overwhelms the scaffolding.
Yep.
So if that connective tissue is effectively operating at a deficit for 6 to 12 months, how are we supposed to know when it is actually safe to increase physical demand? Like, you can't just guess based on how tired you feel.
No, you definitely can't guess. And this brings us to the 3 to 6 month functional reassessment window. The specialized clinical protocols rely on something called the balloon test.
Okay, the balloon test. I saw this in the sources and it's fascinating. Tell us about this.
So around 3 to 6 months, the focus shifts from, are the acute wounds closed to, is the system functioning cohesively? The balloon test is a brilliant way to assess the deep reflexive mechanics of the body.
How does it work?
You lie flat on your back with your hips and knees bent to about a 90-degree angle. This neutralizes the pelvis. Then you forcefully blow up a balloon.
And that exhalation creates a massive spike in intra-abdominal pressure, right? Like it pushes down on everything.
Exactly. It mimics the pressure of a cough or a jump. In a healthy, fully functioning core and pelvic floor system, that sudden downward pressure should force your deep core and your pelvic floor muscles to contract reflexively.
So you shouldn't have to consciously think about doing a Kegel.
Right, no conscious effort. The muscle fibers should naturally sense the pressure and respond with a feeling of closure and a slight upward lift to support the organs.
Okay, so what happens mechanically if that reflex is broken? Like, what does the patient actually feel?
Well, if the tissues lack that reflexive coordination, the pressure simply pushes outward and downward. So you'd feel a distinct outward bulge in the abdomen or a heavy downward pressure in the vaginal canal.
So the system is misfiring.
Yeah, it's failing to rise to meet the challenge of increased abdominal pressure.
Wait, let me ask a clarifying question here. Does blowing into a balloon repeatedly actually fix the problem by training the muscles, or is this purely diagnostic?
Oh, it's purely diagnostic.
Okay, because if we think of the pelvic floor like a safety net or a hammock catching the weight of the organs, if you jump into the hammock and the ropes don't pull taut automatically, the net needs tightening. Does the balloon test tighten the hammock?
No, it's purely an alarm bell. It tells you the hammock is loose. If the tissues aren't reflexively catching the weight of your organs during a simple balloon exhalation, it indicates an absolute need for targeted pelvic floor physical therapy to retrain that neural reflex.
Right, because if that reflexive net fails during a simple breath, introducing the physics of running is just a recipe for disaster.
A complete disaster. Which is why the specialized clinic guidelines are incredibly strict here. Retraining to high-impact activities like running should never happen before 3 months postpartum, period.
I noticed they were very firm on that in the sources.
Very firm. And even at 3 months, it requires a functional reassessment because running generates ground reaction forces that push up to 3 or 4 times your body weight directly into the pelvic floor with every single rapid single-leg hop.
That is a massive mechanical load.
It is.
And the gauntlet you have to run to get cleared for high impact is intense. I mean, to pass the reassessment, you must perform 20 single-leg bridges, 10 single-leg squats, and 10 forward bounds, completely free of any vaginal heaviness or urinary leakage.
Yep, that's the baseline.
Sending recovering tissue out for a 3-mile run without passing that baseline test is practically guaranteeing long-term prolapse or worsening laxity.
Exactly. The physical load has to be matched by tissue readiness. You can't just power through it.
Okay, so let's assume a patient does everything perfectly. They wait out the 3 to 6 month window. They are diligent with pelvic floor physical therapy. The muscles of the hammock are as strong as voluntary exercise can make them, yet the persistent feeling of looseness and profound vaginal dryness remains.
Right. The mechanical tissue healing, the physical rebuilding of the muscles hits a plateau.
Why does it hit a plateau?
Because of a completely different biological roadblock. We have to look at the endocrine system now. The diagnosis we are focusing on here is genitourinary syndrome of lactation, or GSL.
Which is such a mouthful.
It is, but it describes a direct physiological conflict between feeding an infant and healing the mother's pelvic tissues.
That is so wild to me. The biological act of producing milk actively delays the mother's physical healing. It seems so unfair.
It does seem unfair, but it's basic endocrinology. Breastfeeding requires the pituitary gland to produce high levels of a hormone called prolactin. Prolactin stimulates milk synthesis, but it simultaneously suppresses estrogen production.
And estrogen's important here.
Crucial. Estrogen is the fundamental building block for tissue repair. It stimulates the fibroblasts in your tissue to produce collagen and hyaluronic acid.
So if the cells are the bricks, estrogen is the mortar holding the entire structure together and keeping it flexible.
That's exactly it. Without adequate estrogen, the vaginal lining becomes paper-thin, dry, and highly fragile. The tissue is structurally deprived of the fuel it needs to recover from the stretching and tearing of childbirth.
Okay, so following that logic, if estrogen is the mortar, does weaning the baby magically supply the mortar and fix the laxity? Or is this structural damage already done by that point?
It's a bit of both. Weaning initiates a rebound in systemic estrogen levels, which slowly restores the moisture and thickness of the vaginal mucosa.
Okay, so that helps.
It does. But if the deeper connective tissue was starved of estrogen during the critical early months of wound healing, especially after severe trauma like a third or fourth degree perineal tear, the structural integrity might be permanently compromised.
Oh, wow.
Yeah, the body basically laid down inferior scar tissue instead of healthy elastic collagen because it just didn't have the right hormonal tools at the time.
So what are we
Yeah.
doing about this? Because you can't just tell people not to breastfeed if they want to heal.
No, of course not. And that's where the newer clinical trials come in. They are actively exploring the use of topical intravaginal estrogen cream in the early postpartum period for breastfeeding women.
So it's localized.
Exactly. It provides localized estrogen directly to the vaginal tissues to boost collagen synthesis and improve that wound healing without spiking systemic blood levels of estrogen.
Which is important because systemic estrogen would interfere with the prolactin needed for milk production, right?
Spot on. It delivers the mortar directly to the construction site without shutting down the milk factory.
That is brilliant. Okay, so we've mapped the 6-week acute phase, the 3 to 6 month functional reassessment, and the hormonal complications of lactation. Let's move to the 1-year mark.
The 1-year reassessment.
Right. So a year has passed. Hormones have normalized. Physical therapy has maximized muscle strength. But the connective tissue laxity persists. The body's biological healing cascade have officially plateaued. What can medical technology offer when natural healing hits a wall?
When conservative measures hit their limit, we look at intervening in the deep connective tissues. And the aesthetic and functional medical space has heavily invested in radiofrequency technology for this.
Like the Viviv or Thermiva devices mentioned in the sources.
Exactly. These use non-ablative radiofrequency energy.
Okay, non-ablative meaning they aren't cutting, burning, or destroying the surface layer of the skin. So how does a device bypass the surface tissue to tighten the fascia underneath?
It's pretty clever. These devices use specialized cooling pips to protect the delicate mucosal surface of the vaginal wall while simultaneously emitting radio waves that penetrate deeper into the connective tissue layer.
And what do the radio waves do down there?
The radiofrequency energy agitates the water molecules in the deep tissue, which creates friction and controlled heat.
Why do we want to heat the tissue? That sounds counterintuitive.
Well, safely elevating the temperature of the deep fascia triggers a controlled inflammatory response. The body interprets this thermal stress as a minor injury and initiates a massive wound healing cascade.
So it's tricking the body into healing itself again.
Yes, it recruits fibroblasts to the area, which spin brand new type I collagen and elastin fibers. Over a period of 30 to 90 days, this biological response thickens and tightens the vaginal wall from the inside out, restoring the structural integrity of that hammock we talked about earlier.
Hold on, let me push back a little here. We are talking about out-of-pocket, highly marketed technology. Aren't a lot of these radiofrequency treatments just preying on postpartum insecurities? I mean, it sounds dangerously close to the cosmetic beauty industry. How is this a genuine medical intervention for a physical injury?
That is a very valid point, and honestly, skepticism is required when evaluating this space. The distinction really comes down to measurable functional improvements versus subjective aesthetic desires.
Right, function over just how something looks.
Exactly. Vaginal laxity often presents alongside reduced sexual sensation, uncomfortable friction, and mild stress urinary incontinence. When a technology improves the deep collagen structure enough to stop a patient from leaking urine when they sneeze, it crosses the boundary from cosmetic enhancement into a valid functional medical intervention.
The data has to back up the functional claims.
It does.
And the sources actually highlighted a major study on the VV radiofrequency device. It was a randomized, sham-controlled study.
Yes, meaning it was tested against a placebo machine. That's
Yeah.
the gold standard.
What did they find?
The results were statistically significant. Women who received the actual radiofrequency treatment were over 3 times more likely to report no vaginal laxity at the 6-month mark compared to the placebo group.
Wow, 3 times.
Yeah. It demonstrated a measurable biological change in tissue function, not just a placebo effect.
Okay, so radiofrequency has some solid data, but the guidelines wave massive red flags regarding another heavily marketed technology, right? Lasers.
Oh, yes.
The laser controversy. CO2 and erbium lasers are frequently advertised for vaginal tightening, but leading bodies like the International Continence Society, the ICS, and the FDA have issued strict warnings against routine laser use for atrophy or laxity.
They have, because the mechanism of action is entirely different, and the evidence simply isn't there to support it. Lasers are ablative. They work by vaporizing the water inside the tissue, which creates micro-injuries on the surface.
So they are essentially burning the tissue to force a healing response.
Yes, precisely. The FDA and ICS warn that the histological changes observed after laser treatments, the stiffening that a patient might interpret as tightening, could actually just be fibrotic scarring resulting from a thermal burn.
Oh, so it's laying down rigid scar tissue, not regenerating healthy, flexible, functional collagen.
Exactly. Scarring the tissue tight is fundamentally different than rebuilding a flexible, supportive fascial matrix.
That is a critical distinction for anyone, navigating these treatment options. You want flexibility, not just rigidity.
Definitely.
What about surgical intervention? Does that have a place here?
Well, surgery like a vaginoplasty or a perineoplasty is really reserved for anatomical failure.
Meaning?
If the laxity is accompanied by diagnosed pelvic organ prolapse, where the bladder or rectum has physically descended into the vaginal space, then surgery is required to manually repair the anatomical defect.
But not just for laxity on its own.
No. Major gynecological associations are unanimous that surgery should never be performed solely for a subjective feeling of looseness without an underlying prolapse diagnosis.
Got it. So pulling this entire timeline together for you, the listener, childbirth-related laxity requires ongoing, staged reassessment.
Very much an ongoing process.
The 6-week checkup is really merely a starting line to confirm acute wound closure. The true test of the pelvic floor's reflexive strength happens in the 3 to 6 month window using tools like the balloon test, well before any return to high-impact activities like running.
And you have to factor in the hormonal piece. The biological reality of genitourinary syndrome of lactation must be considered for breastfeeding mothers because that lack of estrogen drastically alters the tissue's ability to heal.
Right. And finally, if symptoms persist past the 1-year mark, navigating the world of medical technology requires understanding the profound difference between the deep collagen synthesis of radiofrequency and the potential fibrotic scarring of lasers.
It's all about functional recovery.
It really is. I mean, we have concrete biological data proving that connective tissues require over a year to reach 80% strength, and that hormonal suppression stalls cellular repair for months.
Which leads to a really interesting question, actually.
What's that?
Well, if we know all of this, we have the biological data, it leaves you wondering, if we treated postpartum physical recovery with the same multi-year insurance-backed physical therapy protocols as an ACL tear or hip replacement, how drastically would we shrink the global rates of female pelvic organ surgery later in life?
Oh, wow. That is a great point. We wouldn't accept a 6-week clearance for a blown knee, and we shouldn't accept it for the pelvic floor. I love that. Well, thanks for taking this deep dive with us. Keep questioning the consensus, keep looking at the data, and we'll catch you next time.